I'd like to welcome all of my fellow trustees and board directors, as well as a lot of CEOs and other dignitaries with us this evening, for what I think is going to be a very interesting time we're going to spend together talking about quality and governance, and then some conversations you'll be able to have at your own tables as well. For those who have not met, I am Jeff Lowe, and I am the chair of the board of directors of the Southwest LHIN. And I know that probably most of you have been here for the entire day, and Mike did an excellent wrap-up at the end of the day today, so I'm not going to take us through that again, if you can understand me on that. And I'm probably a bit tired, but we would ask you to bear with us for a little bit longer for, I think, what's going to be an excellent speaker this afternoon. Our focus on quality is not just a single-minded, not a single direction, if you will. And we've talked about a number of different avenues as it affects quality today, on the elder side or the acceptance side, on the technology side, and certainly the excellent presentation that was done earlier by Dr. Maher. Throughout the world, it's recognized that the quality healthcare that focuses on the patient is essential in ensuring that people remain well. Certainly well when they're discharged from hospital, for example, and that the communities they live in can provide such additional supports that are necessary on either a long-term or a short-term basis. It means that care is built around the patient rather than the other way around. We talk about this constantly at our board table at the Southwest LHIN, and that is the patient-centered care, access to care, and the work that's done through all the health service providers in the Southwest that impact that. Last year we heard from Jim Easton, and Dr. Easton, the massive challenges he faced in the National Health Service in the UK. This year, as I said previously, Dr. Maher spoke of learning from patients themselves. It seems like such a natural idea. I think the older you get, the more comfortable you are talking with your doctor, because the doctors get younger. Well, they do. I'm not getting older. And the conversation becomes a little easier, but I do know, from my own kids, for example, that there still is a stigmatism of getting some information. And I think that the presentation she made was excellent. So after all, we're the people receiving the health care. We're the people that know ourselves better than anybody else. It's like my swimming pool. We do a lot of engagement, but are we doing the engagement with the right people? Dr. Mahar's presentation again showed us that we should never presume to know what someone else's needs are until we know them intimately and they know us. Unfortunately, sometimes in healthcare, we're a little bit notorious for engaging the professional community, that's the doctors, the clinicians, senior administration, with the assumption that they know what is best for their clients and their patients. And these are well-educated and very well-meaning people. In fact, all the time I've spent at the Southwest LHIN to date, I don't think I've met anyone who is not genuine. And I've not met anyone who doesn't want the very best for their patient, for their community, for the family, for the people they work with. However, just asking the patient directly almost seems too simple. And we talked about that toilet paper issue. I guess they call it, there's a bathroom tissue. I always call it toilet paper. I always keep mine on the floor. That way I can move it anywhere I want, particularly with my toes if I have to. Because I usually can't get it on the roll anyways. If you notice anymore, the rolls are too big for the dispenser. So if you get it on the wall, it breaks off one sheet at a time. Anyhow, I thought that was a great idea. Dr. Moore spoke of how, as a society, we can easily become blind to the needs of others, particularly the elderly, until one day we wake up and we are the elderly. And believe me, I got all kinds of aches and pains I'd like to tell you about, but I'm sure you don't want to hear about them. You know, can barely see out of one eye, can barely get up in the morning, hobble to the bathroom in the morning. You know what I'm talking about. Her experiment demonstrated we're often oblivious to changing needs as we move through the life cycle. Looking out from the patient or client perspective rather than looking in from a provider perspective frequently yields a better quality of life for everybody. When hearing the presentation by Kelly and Gore on quality improvement and the enabling framework, it seems basic, but of course we want quality in all we do. But some of the most simple basic concepts can be some of the most difficult to implement. Quality takes time, quality takes determination, and it takes passion. And yes, quality may cost more money at the outset, but the ultimate impact along the continuum of care will be huge, and there's empirical evidence to support that. Never has there been more truth to the saying, you get what you pay for. Take the time to develop and implement quality processes, and the results will stand the test of time. So where does that leave us, governors, boards of directors, different directors? What role do we play? And I think it's a huge role. It's not a role of holding feet to fire. It's a role of ensuring that the policies, procedures, if you will, the rules of the game are in place to enable health service providers at every level provide quality health service. We don't treat patients as governors. We don't wield a scalpel. We don't help the elderly with their everyday activities, except at my place. Yet the decisions we make in the boardrooms of our respective organizations have a direct link to the quality of care that is provided. We are in fact called upon to make decisions on how to spend health care dollars to get maximum value for money, to fund programs that will allow the frontline worker to do what he or she does best, which is to deliver quality health care to clients and patients. So if that is a bit of a background, I'm pleased to introduce this afternoon our speaker for the next little while, Dr. Ben Chan, President and CEO of Health Quality Ontario. You'll note that Dr. Chan was originally scheduled to present with LHIN McLeod, and as Mike mentioned this morning, Ms. McLeod, well, she had other things to do. She's off with her daughter in Nova Scotia and their newest grandchild. We understand everyone's fine, by the way, and I did see some notes of congratulations going to Ms. McLeod, and I saw some people texting her today too, so some people must know her. I don't, sorry. But I know we're in excellent hands with Dr. Chan, who's been involved in the quality aspect of healthcare for many years. And he's going to be with us today to talk about Health Quality Ontario's strategic plan. So in the interest of time, in the interest of who you actually want to hear from, I'll call on Dr. Ben Chan.
Good afternoon. It's indeed a great pleasure to be here to talk to you about Ontario's quality agenda, but very importantly, not just about what Health Quality Ontario is doing or the activities, but what do your organizations, how are they going to be linking up to the broader quality agenda? And for your position as a board member, what are the things that you are going to be needing to be doing and thinking and creating around quality that will tie in directly with what are going to be the broader quality priorities and agendas of the province? What are going to be your specific responsibilities in driving quality? And that's indeed the discussion that I hope we have. It won't be just me talking, but I hope we'll have some opportunity to have some dialogue amongst you and in the room to think more deeply about that. It's also a particular pleasure to be here in the Southwest LHIN. It's actually a part of the province that I've had a great opportunity to get to know better over the past several years. Many of you know that in addition to being the CEO of Health Quality Ontario, I've tenaciously hung on to my clinical practice and still aim to do about 2 or 3 weeks of clinical work across the province. I've had the opportunity to locum and do primary care and emergency department coverage in Exeter, in Clinton, in Chesley, Walkerton, in Durham, a variety of these things. I'm thrilled to be back here this summer. Actually, I'm going to pick up a number of emerge shifts in Southampton and Listowel as well, and it helps me keep connected with what's happening right here on the front, in the cold face of care. So many of you know, in fact all of you know, I've heard of the Excellent Care for All Act. Sure. The Excellent Care for All Act is indeed, it's a very interesting and fabulous piece of legislation. I've had the opportunity to work in Saskatchewan and other provinces and to see what's happening. I believe this act is unique. And I think it's a defining moment when it was produced in about 2 years ago. It certainly created a number of changes for Health Quality Ontario in terms of an expansion of our mandate. But it imposed, in fact, created a number of very specific obligations for healthcare organizations, starting with the board. And these are to be phased in over time. As I saw from Michael's poll, probably about less than a quarter of you are from the hospital sector. Is that about right? And many of you are from the community sector, is that right? Primary care, I think there were some CHCs. So even though the first year and a half of actual experience has been with the hospitals, this is an act that is coming to you sometime for certain in the next few years. So what are some of the things that your organizations will be required to be doing in the future, and things that you could actually start thinking about even now before it becomes mandatory? One, submit an annual quality plan. And an annual quality plan very specifically talks about, you're going to set some specific numeric goals for improvement in the year. And these are goals, if I read the legislation, where it's an actual quality measure of some sort. It's not saying our goal is to create a falls prevention program. If that's what you want to do, your goal is, we're going to actually aim to take a dent in the rate of falls in a particular community. And we're going to actually set a specific time frame for that to happen. And there are going to be elements of that that are going to be tied to executive compensation. At this point, it's at the discretion of boards as to what they tie to executive compensation and how much they tie to executive compensation. There's a requirement to establish a committee of the board that focuses on quality issues. And there are a number of different regulations that with regards to who needs to sit on that committee that have been developed specifically for hospitals. It'll be interesting to see how that plays out. But certainly key clinical leaders, for example, are individuals that were expected to be part of the quality committee of boards for hospitals. Establish a patient relations process. Have annual patient satisfaction surveys. That's the way that it's worded in the legislation. Actually, I think we can go further and talk more about broader aspects of the patient's experience as Dr. Maher challenged us to do, as well as biannual workforce satisfaction surveys. And as I said, applies first to hospitals and then eventually to all organizations. And this is a great opportunity. Does this mean that we have to wait until the legislation applies to us, in different community sectors before we implement this? Or can we seize the moment and think about how can we actually start applying this today so we can get a jump start and get ready for this quality agenda? What are the priorities that organizations can be want to be choosing in their plans, and what to be focusing on? There's a gazillion different things that we could all be working on in each of our different areas of focus. Sometimes we have a tendency to want to focus on things that are directly within our control, that happen within the four walls of our organization. And hence it's not surprising that hand hygiene was by far and away the number one most popular topic in the hospital plans of quality. But what indeed are the really tough, seemingly difficult to deal with challenges that our system keeps facing? So I'm just going to run through some major themes that we're seeing in the quality monitor report that we've been reporting year after year after year. But just a quick show of hands. Who here has received a copy of the quality monitor report in the past? So actually, only about half of the room. So the next edition, just to give a little plug, the next edition is coming out by the end of June. And so please, we send this a hard copy to every healthcare organization in the province. And if you haven't received it, by all means, please go to our website and you can download it or send us a request for additional copies. So what are some of the big challenges? This should be no surprise to all of us. We have flow of people throughout from one part of the system to the next, flow of people from emergency departments to hospital beds, from hospital beds to home settings, to primary care and home care, from both those settings into long-term care. Indeed, this is indeed very much a cycle. This is just one part of the cycle that we are showing. But when we have problems in one part of the healthcare system, if we have backflows in long-term care, what kind of ripple effects does that create? If we have problems with access to services in the primary care or community care sector, what kind of impacts does it have elsewhere? If we have poor handoffs from one part of the system, as patients are moving from hospitals, what kind of impact does that have on ourselves in trying to do the best possible job if we're working in the community sector? We are all closely and tightly interdependent. And it's our belief that, sure, hand hygiene in hospitals may be one thing, there's good in doing that, but the really tough questions are going to require a much greater degree of interdependency between the different parts of the healthcare system. And what are some of the key findings that we report on from year to year? One is that long-term care waits are very high. In fact, about 3.5 months overall. For people who are waiting from home, they're about 6 months. For people who are waiting from hospital, waits are about 2 months. The good news is that, and they're about 3 times higher than what they were at its lowest point sometime in 2005. The good news is at least they've stopped increasing because they've had a long trajectory. But in our opinion, this is still far too high for people to be waiting. Yet ironically, many people, about 22% of people are admitted to long-term care who don't necessarily need to be there. They are rated on the MAPLE score as not having high or very high needs. Which suggests that if they had other alternatives to them available in the community, that there would be a good likelihood that we could be able to serve those individuals with better home care, better supportive housing, better day programs, or other alternatives to long-term care. Primary care access. The government has spent a lot of money and resources on reducing the problem of people, unattached patients, and certainly that has decreased quite nicely over the last several years, from 8.2 to 6.5% of people, adults without a family doctor. But our big problem right now is making sure that people get it seen in a timely basis. Only half of people can see their family doctor on the same day or the next day, and as you see on these statistics, we are far worse than almost all these 15 industrialized countries that we compare ourselves to. On chronic disease management, what's happening in primary care, what's happening in our CHCs and our family health teams and fee-for-service physicians, is that we still have a lot of opportunities to improve. There's still a lot of evidence-based best practices that we could be optimizing, making sure people are on the right drugs. That's improving over time, but we believe there's still room for improvement. And even basic things, like making sure people have an eye or a foot exam done on a regular basis. We're only doing that right about half the time. And there's huge opportunities for us to keep people healthier and delay the time that before they need to seek acute care. Other issues that we are seeing from the data, we have a growing elderly population, more and more people with chronic conditions, people that are frail and living in the communities. One of the important things is to try to keep them safe. And yet we see things like falls, safety issues like falls, still being quite common amongst this population. But there's about 8.8 falls resulting in emergency department for every 100 long-term care residents per year. And an astonishing 28% of people who are long-stay home care clients, people who have ongoing needs and are being visited regularly, 28% will have a fall over the past 90 days, and a proportion of those will have an injury related to those falls. And these are also common in other settings. Other things about the handoffs from one part of the system to the next. When people, particularly the frail elderly, or people with multiple chronic conditions or medical conditions, when they leave the hospital, how well equipped are they to be able to function well at home? How good is the information that they get? Well, astonishingly, across a variety of different indicators, about a third of the time, people leave hospital without basic information about what they need to do to do well. And that includes things like, who should I call if I need help? About a third of people don't know that. When should I resume usual activities? About half of people don't know the answer to that information. Similarly, for side effects of medications, of the proper use of medications, that's perhaps the best of those measures. But still, if people aren't leaving hospital with this critical information, what do you think might happen to them? It's much more likely they're going to be readmitted. And indeed, readmissions are indeed very common for certain conditions, such as congestive heart failure or COPD, where about 1 in 5 patients are readmitted within 30 days. And we believe that there's lots that we can be doing to improve that transition to decrease these readmissions. In particular, mental health. Who works in mental health? So there's quite a good number of you. This is another issue that we have in terms of the transitions of people that are moving from one part of the system to the next. We also see major problems with readmission rates, perhaps not as high as CHF, but they're still common. But many people, in fact about a quarter to a third, depending on the exact diagnosis, of people with mental health conditions aren't even followed up by a physician within 30 days of their discharge. And that we believe there's an important opportunity for us to make some improvements in making sure people are followed up appropriately. And again, if we have all these other issues or problems, and we have long-term care backups, that in turn creates pressures in our hospitals, that in turn can make it very difficult for us to clear our emergency departments. We've made some progress on emergency department wait times over the last few years, but that progress has been very slow, and we're still far from the targets that the government has set for emergency department wait times. And ALC is also, as many of you are aware, I guess if we're having difficulties with getting people placed in long-term care, if we're having difficulties finding alternatives for people in home care, then the implication of that is that it blacks up into the system and leads to this persistent problem with now 1 in 6 patients in hospital occupying bed when they could be better served elsewhere out in the community where most of you are working. So here, in summary, the big system-wide pressures across our healthcare system: management of chronic diseases and the frail elderly, primary care access, smooth transitions of care particularly from between hospitals and community care, but also between other transfer points in the system, making sure people have good, solid access to home care or alternatives to long-term care. Dealing with the ALC issue and the emergency department waits, especially for admitted patients. And really the point that I'm trying to make here is that as you're embarking your quality journey, think, there's all these things that you may be wanting to aspire to do, but how are you really going to develop a strong progress and improvement? And for these tough challenges, the activities of one sector strongly influence another. How can we really dig our heels and try to attack some of these problems? And I know, as I said a moment ago, a lot of the hospitals are choosing things to work on that are within their 4 walls, like hospital-acquired infections or hand hygiene, and that's important that we still pay attention to those issues. But there's at the same time been a real reluctance. Much smaller numbers of hospitals are putting ALC as a priority 1 on their quality improvement plans. Very few hospitals are putting readmissions on their quality improvement plans. And that's because, we suspect, because to really have progress, you need to be connecting and partnering with other parts of the system in order to make that happen. The same could be thought of in terms of your own organization. So what I'd like to do is stop here for a moment and ask, and I'd like to, we'll just do this for 5 minutes. And I'd like you to think through a few points here. What are indeed some of the key priorities for your organization for quality, and how do those priorities align with some of these 5 or 6 big system-wide pressures in the system? Are they aligning with the priorities of other organizations in the system? And if you think about your priorities that you want to accomplish, what other organizations do you need? Other sectors of the system, other organizations, do you need to be working with? Have you had discussions with those organizations? Have you tried, what kind of discussions have you had about creating some kind of a common plan to tackle some of these different areas? Have you had are you developing these partnerships, or is a lot of your work still being done kind of focusing on your own organizations? let's take a moment no more than about, let's say, just about 4 or 5 minutes, and if you can just, amongst your tables, just have this discussion around some of these questions. Okay, why don't we just reconvene now for just a moment. I see there's a lot of active discussion here for a moment. We don't have time to do a full debrief of this session. Perhaps there's going to be some moments afterwards where you'll be able to, in the discussion afterwards, where you'll have an opportunity to talk in more detail about some of these questions. I did try to tune in on 1 or 2 tables, and very lively points. I think one discussion thread that I heard was, some of our agencies in the community are small. We don't have the same kind of resources as hospitals in carrying out the agenda. But I think part of the things we were talking about is, are there opportunities in which you can partner with the hospitals who have the resources and who are indeed dealing with the brunt of heavy demand on their services as a result of things that may not be working or as well supported in the community. Are there opportunities to create those types of partnerships and create some kind of a common plan? So those are some of the things interesting threads that I picked up on. Critical part of the Act is going to be talking about setting a vision and a definable vision. As you saw in the Act, you got to be now setting some very specific targets. It's not just a matter of having a vision statement, but it's got to have some targets. And is it a definable, measurable target with a specific time frame for completion? One of my favorite quotes from my hero, Don Berwick from the IHI. Some is not a number, soon is not a time. I never thought I'd live to the day when his famous quote would now be embedded in a piece of Ontario legislation. I think that's pretty cool. So let's be thinking about some hard and firm targets. And are we going to be talking about measures that actually mean something to people? If you describe your plan and what you want to accomplish at a cocktail party to a layperson, they're going to say, wow, that's great. Is it something meaningful we're going to create? Again, is it a matter of we're going to create some particular program to do this, or is it something that's going to be exciting when you describe it? So we're going to cut the wait times for access to this from this level to this level, or we're going to serve this, increase our ability to serve people in the community by this level, or we're going to attain some level of success rate with some program that we are working with, perhaps on the mental health side. Just going to skip that slide. What are some of the approaches? This was trying to develop, now what I want to do is talk a little bit about the experience from hospitals last year, not to be hospital focused, but to think and help your organizations. What can we learn from the struggles that hospitals had in their first year? One of the toughest struggles was, how do I set that darn target? Where do I get this number from? Am I just pulling it out of a hat? And we looked at the plans, we looked at what the literature suggests, and we've put forward some ideas on how you set a target, and a stretch target. It's important. I think all the literature suggests that if you're going to set a target, set some limited number of priorities and try to make a big difference, not just a small difference. People aren't going to get excited in your organizations if you're just planning to make some kind of a really minuscule improvement. Some of the things we saw, in some cases, it's you want to go for a theoretical maximum. We saw this particularly for some compliance measures where there was a process like a surgical checklist or a checklist of things you need to do to try to prevent a blood clot, thromboembolism, and people were aiming for 100% compliance with that. There were a number of instances where people were aiming for the best results that had been achieved anywhere, and in some places have eliminated certain types of hospital infections, and other places, and Queensway Carleton was aiming to do the same thing. Another possibility is to look at the 90th percentile. Another instance is if you have something that you're doing where you can think of it as an actual defect. You actually have the defect rate of something that should be happening all the time, but it's not. Then think about how can you cut the defects by half. So for example, St. Mike's, its hand hygiene rate was 65%. Well, think of that as a 35% defect rate. And they were aiming to try to cut that defect rate by half. This is in our quality improvement a guide and resources that we've developed for the hospital sector, and it's all available on our website. Some indicators move very slowly, even despite your best efforts. HSMR, hospital mortality, is one example, but something that's relevant to all of you. It's patient experience, your global satisfaction measures. It's very difficult to move it more than a couple of percentage points a year. And so you look at what's been accomplished elsewhere to try to figure that out. That's on your global measure, but on an individual measure, say if you're just focusing on communication or discharge transitions, you might be able to aim for a much higher incremental change in the course of the year, so like 5 or 10%. 10% might be a bit high. Some places said, well, let's aim for the average. Now, is that what we really want to be aiming for? That might be appropriate if you're like way down in the 10th percentile to be aiming for the average. But if you're already fairly close to that, we want to encourage organizations to be shooting for something that's much higher towards the stars, a much more ambitious target. So those are some of the rough guidelines that we uncovered and we've put forward, and guidelines that you can generically apply in your board discussions as you're trying to think about your targets. What are examples of some not so stretched targets that we saw in the hospital quality improvement plans? We saw a number of instances where people were aiming for a 1% relative improvement, like let's increase our hand hygiene rate from 79% to 80%, or our readmission rate from 14.6 to 14.4%. I think, or not setting an improvement at all and saying that was your top priority. I think we can do a lot better than that in terms of the ambitiousness. We also saw a few examples where the target set was worse than the current performance, where the mortality rate being targeted was worse than the actual. We don't recommend that. I think you may have a bit of challenges with that if a reporter ever got a hold of that. And we're not quite sure why that was happening. There may be some instances where organizations thought, well, I'm already doing fine, and maybe, all I need to do is I'm already above average, I just need to be average. There are some places that actually quoted that, and again, that's not what we're trying to aim for. We're not aiming for just average, because average, in a lot of instances, doesn't mean that it's the best that we could possibly be. So another quick discussion point. So, I know we have hospitals and they've done the quality improvement plans. For those of you who are not hospitals, who here has, in your board, developed a true blue quality improvement plan where you've actually picked some outcome measures or experience measures or something relevant to patients, and as a board, you've actually set some numeric targets for improvement with a specific time frame? And for those of you, and so just a couple of hands there, and for those of you in the community sector, put your hand if you haven't kind of had a chance to do that type of exercise. Okay, so this is going to be, indeed, this is a great opportunity for your organization to jump even before this becomes mandated. What, in fact, are we thinking about in terms of our quality improvement plans? Do we have any numeric targets? Or, if you don't have a numeric target, and what are some of the things that are quite obvious ideas for what you could be setting as a numeric target for improvement with a time frame? And do you have any thoughts as to what might be a stretch target? And what would you choose? What indicators would you choose that actually you're sure that if you were to describe this would be meaningful to patients? And I'll skip that last point just in the interest of time about how you market this. Let's stick with just the first couple of questions. What targets could you be setting if you don't have one? What numeric targets, and what would you choose? What indicators would you choose that would be something really meaningful to patients? Let's take about another 5 minutes to have that quick discussion. Moment. I know a lot of people are deep in discussion, and if I could just have your attention back here for a moment. I had, again, the opportunity to be a fly in the wall at a number of the different tables, and some of the things I was hearing was some community-based programs, mental health programs say, well, let's start thinking about what our wait times to get into our services are going to be as one possibility of what could be in our target. Another group was struggling. Well, we don't have a direct intake, but we see people on an ongoing basis with with chronic disabilities. And then there are questions about what kind of, are there any safety issues that are important that we need to, like falls that we should be addressing, or is there, is there some other aspect about how you get people back to function that we could be thinking about. So a number of good ideas that were flowing about what we could be picking, right, some of our big targets, and a lot of questions about measurement as well. I know it's no surprise, part of the reason we went first with, I think part of the reason the government went first with hospitals is because they got tons of data. Not quite so with the community-based sector. We haven't had the rich traditions. That shouldn't stop us necessarily from collecting data. There are opportunities, if you're looking at wait times, opportunities that you can be doing even just kind of periodic samples of your wait list, of people that are on your intake process, and tracking those individuals as a quick way of getting some data on wait lists, if that's something that you're looking at. Strategy, another kind of the other key point, I'm going to try to keep this close, make this as short as possible since we're getting close to the end of our time. But the strategy. So you make a great target, but how are you going to get there? And again, what are our learnings from what's been happening? And organizations really struggled with articulating. Many hospitals, I guess there was wide variation. Some hospitals had a very clear and detailed description of what they were going to do in order to achieve their target, and others didn't put any information at all. They left that section blank, or they might have put one or two things. So the question is, if you're going to be successful, how are you going to describe your strategy? And we want to put forward two concepts. One is, what are the evidence-based best practices that should be implemented? Things that you should, drugs or certain tests or certain types of monitoring or a particular type of therapy that, if you do this, the randomized controlled trial says you get this kind of benefit from it. And then there's another, that's the what about what you should be doing. And then there's another piece, is the how are you going to make sure that's done, not just 50% of the time, but 100% of the time. Because very often, are our practice guidelines followed by all clinicians out there? No. In fact, lots of evidence suggests that depending on the guideline, we often miss implementation by as much as 50%. So in terms of the evidence, just as a little example, if you're thinking of diabetes, there's certain things that the controlled trials tell us you should be doing, making sure they get regular blood work, checking their feet, checking their eyes, keeping their blood pressure, cholesterol, their blood sugar at a certain level, doing things like self-management. And there's other examples of very specific evidence-based activities that you should be doing. And that can be an important part of your strategy. But then there's a question of, again, how do you make sure that all that stuff is happening? Remember that slide I showed you where only 50% of the time people get a foot exam or an eye exam, that it's done on time? How can that be? The guidelines tell us it's in black and white. And what we've identified at Health Quality Ontario is 7 generic root causes as to why best practices are not adopted that are universally applicable to any organization in the system. People may just forget that what they were supposed to do because we all get too busy. They may think that they're doing a good job, but when you actually show them the data of how they're doing, they say, holy smokes, I'm not doing as well as I can. And there may be very inconsistent processes. The intake process for your service may be different from one community to the next, to the next, to the next. And that just creates lots of confusion for everybody involved. There's a hospital. If it's a long-term care home, maybe things are done differently on the day shift versus the night shift. Do people have the right skills? And have we checked whether or not people have the right skills to perform certain types of tasks? Do we have some imbalance in the resources in the system? Very much related to the discussions we had with your earlier talks. How well are we truly engaging people in the delivery of care, in their decision-making, in the design of care? And last but not least, what's the accountability for making change? What are the incentives or motivation for people to change? And I'm not rushing through this, my slides will be available, but here are some generic things that any organization can be thinking about to make sure that it cements the best practices and does them consistently. Do you have some way of telling people on a real-time basis, your staff, how well you're doing? If you're tracking wait times, Do you have like an ability to feedback? This week, every week, we know what our wait times are, and we're constantly tracking them. Reminder systems or clinical decision supports. If you have a list of different things you should be doing, like making sure that a certain drug is done, or making sure a certain test is done at a certain time period, do you have things like checklists or reminders in your electronic records to make sure that people are doing the right thing? Process improvement. Are you mapping out all the different processes that happen? Are you making sure that people are getting the right training, but not just training, but skills verification? That it's not we're just sending people on a training course, we're actually verifying whether or not they adopted the skill. Patient engagement are the things that, what are the different ideas? The ideas that you heard today about how we can involve people in the design. And what are we doing to make sure that people are really buying into the changes that we want to make? And that could be on the positive thing, like recognition and rewards. It could be things like making sure that our executives are walking around and constantly reinforcing the message that this is important. It could be clear accountability systems in your organization. Of all the different best practices that you want to implement, you have some clear individuals in the organization that are accountable for this. Now, one question I often get asked is, I'm a board member, am I supposed to am I supposed to, is my job to tell the CEO what to do for all of these different change ideas? I mean, isn't that micromanagement as a board member? And that's a very tough question. It's an excellent question. And I think the response that, the more I talk with board members and CEOs, here's the response that I think makes the most sense. One is that as a board member, you're not going to try to design each of those different changes, but it's a really fair game to say, our chief executive, have you thought about this root cause? Have you thought, do you think people might forget to do this? What systems have you put in place to remind them of doing it? What systems have you put in place to measure this problem? What systems have you put in place to redesign the process? What did we see with our hospitals? Again, some plans didn't have any change ideas or strategy listed, but many plans listed only one idea, and the favorite was, let's do an in-service. Let's do more education. And that will magically mean that all of these best practices that we want are going to be adopted. And here are just some questions to reflect. Our staff, are we going to attend? If they attend, will they actually learn the service? If they learn the service or they absorb the information, will they actually carry out? And if it's a skill-based, how do we actually verify whether or not they can actually do this properly? Or will their skill decay over time? So you need to have ways of guarding against all of those different areas. Here are some questions for board members. Again, we don't have time to go into this. But these are things that you can take back to your board meetings and think. What does our strategy for improvement looks like? Has it got an evidence base? Have we described what are these different barriers or root causes of what could possibly go wrong in implementing the best practices? And are we trying any of these different ideas or approaches for addressing each of those different best practices? So that's indeed a critical part of what your quality committee and then ultimately the board can be reviewing. I just want to close by talking about the big picture plan for quality, and this is Health Quality Ontario's strategic roadmap. This was just released last week. And I'm just going to skip straight to the bottom part, and not just the vision or mission about the great system that we want, but kind of 5 key roles of Health Quality Ontario and how we hope to be a support to organizations like yourselves. One role is Ontario, we believe, needs some kind of a broad roadmap for quality, some kind of a broad plan, some global targets overall for some of these big things that we've struggled with, like readmissions or chronic disease management or access to primary care. And if we can come to a consensus across the province on what those goals are, then that makes it easier for you to do your planning process because you have something to align with. And what Health Quality Ontario wants to do is to stimulate and push those discussions across the system. We don't want to dictate what those targets are going to be, but we want to make sure we have a facilitated consensus on what we could be trying to accomplish together as a healthcare system. Building the evidence and knowledge. There's a whole branch of Health Quality Ontario that is devoted to developing evidence-based recommendations about what we should be doing. So some of the things that I talked about, for example, on diabetes and specific treatments or surgeries or procedures, those are things that we have a responsibility to evaluate the evidence, evaluate the new technologies as they emerge, and make recommendations about whether or not people should be adopting them. We're also going to make some recommendations on changes to funding formulas in order to support quality based on the evidence. The third arm relates to brokering improvement. And remember how I talked about this is the what we should be doing and the how of actually implementing it. What we're hoping to do is to keep our ear close to the ground, look at the literature, and keep amassing piles and piles of different approaches and ideas that successful organizations have used. So this might mean an organization says, hey, I've got a great checklist that I developed at discharge for making sure everything gets done. So let's put this in a repository and make this generally available for everybody in the healthcare system. Another thing that Health Quality Ontario has done is help support the development of quality improvement experts, people who know how to do process improvement. We've trained about 300 individuals, staff within long-term care homes to do things like how to run a process mapping session in their organization. And we're going to continue to develop and work with partners to develop this type of capacity. Catalyzed spread activities involve, we've got a lot of information we want to get out to the field related to the best practices as well as the different tools, and we'll be using every means possible. We've partnered in the past with LHINs to do learning collaboratives, for example, in Residents First, and you'll see more of that, those types of activities. We'll be looking at partnering with our professional associations and communities of practice to get that information out. And last but not least, our continued work on public reporting. We're moving more towards web-based reporting. Some of the different public reporting websites that you see around the province are over time going to be consolidated within Health Quality Ontario. So this is the place that you'll be able to, in the future, go to get the latest information on comparisons between hospitals on different measures like readmissions or patient experience or falls rates in different long-term care homes. That's already available for many of the homes, and that's where we'll continue to monitor whether or not we're making improvement. With that, thanks very much for your time today and great discussions at the tables. You'll have some more discussions in just a moment, and it's great to have this time, and we very much look forward to a strong partnership and look forward to expanding our role in Health Quality Ontario as being a support to organizations like yourselves in driving your quality agenda. Thank you.
Thanks, Dr. Chan. That was, I think, considerably thought-provoking and obviously a lot of work. A lot of work goes into this, a lot of work we all have to do, and that's part of what we've kind of undertaken as trustees. We're now going to move into another facilitated session. It's going to be relative to and have some relationship with what Dr. Chan was referencing in his presentation. And with our moderator, we're going to ask Leslie Showers to join us to facilitate this part of our session. Leslie is a member of the Southwest LHIN Board-to-Board Reference Group, as well as being the past chair of the Huron-Perth Healthcare Alliance, and in fact been involved with that organization since 2003. Leslie is what you would call an excellent colleague. And I think Mike referenced that this morning, the fact that she was called on Tuesday of this week and freed up her agenda to be able to help facilitate this session this afternoon. That's no small feat if you've been asked to facilitate something and come into it cold turkey, if you will. But she has the knowledge, she has the background, she has the skills, and she has the personality that I know she'll pull this off, and with some dexterity, and I think you'll enjoy the session. In my time in knowing Leslie, which is just a little over a year or so now, she's a great colleague. She's the kind of person you want to work with. She lights up a room when she comes in, and her opinions are worth listening to. That's not to say she's opinionated. She might be at that, but she does have good opinions, and it's well thought out what she does have to say. And I've certainly enjoyed all of my dealings with Leslie, and I think you're going to enjoy the way she's going to facilitate the session right now. So, Leslie, I'll turn it over to you.
thank you, Jeff. I asked Christina to keep the introduction fairly modest, and appreciate that. When I was said yes to Mike on Tuesday, I hadn't read LHIN's bio, and I think everybody did read it, and I thought, oh boy, we just don't really have that much in common, LHIN and I, so I'm replacing her, but I discovered we do have something in common. We're both grandmothers. So I'll look forward to meeting her at some point and being able to chat with her about that. So what we'd like to do this evening, just having you reflect on what you heard today, and those of you that are here just for this evening, reflecting on Dr. Chan's presentation to us about quality and how we as governors will move our quality agenda forward. There are 3 questions that we would like you to consider. And what I'd like to do is divide the room just into 3 parts, and each section will deal with 1 question. So if we could have the first 2, I'll go over the questions in a moment, but the first 2 rows will deal with the first question, the second 2, the second, and the back part of the room, the third. So, number 1, the first question, what one thing will you take back to your organization, or what one thing would you do differently as it relates to quality, reflecting back on today's presentations? Number 2, how would you strengthen your focus on placing patients, clients, residents at the center of their care? And the third question is, in what way could your organization's quality priorities align with other organizations? How do you envision working with partners to improve quality for the populations you serve? And Dr. Chan talked about this. One of the most difficult priorities are the ones that will require coordination. So we want you to start thinking sort of outside the box in that regard. So we're going to take 10 minutes, and at your tables, if you could have some discussion, and I would ask that you record some of your discussion, please, on the paper provided, and the staff will be collecting and collating and summarizing your discussions. And then we're going to open it up to a more generalized discussion, and I'm going to ask people if they would volunteer to share with the group some of the discussion they had, and we'll see if we can get some sort of robust conversation going. So I'll have Christina tell me when 10 minutes is up, and we'll come back and reconvene. Time is running near to the end now. So I heard a lot of good discussion going on, and I've learned a few things myself, so that's excellent. So I think I'd like to start with a volunteer group that might like to share with us the discussion they had at their table. And if you could just give us your question and then just talk to us a little bit about what your discussion was. Any volunteers? Okay, I think it's Amy.
I don't know if you can all hear me. Speak right on. Our question is, what one thing will you take back to your organization or do differently as it relates to quality? There are 3 organizations represented at our table, so I'll just share with you what we talked about. One of the items would be focus the quality issues on patients from their perspective, to have a more collaborative partnership between providers and patients. Another one would be to look at ensuring there's alignment with organization's values, and what I hear them talk about is how we invest in people when they do the administrative grounding with patients to make sure that they are using the evidence-based questioning that's been developed in that organization. Third one is to gather statistics to demonstrate results in a concrete way. So that's trying to quantify benefits of the programs and the services they provide to increase accountability.
That's excellent. Thank you, Amy.
Thank you. So our group, the thing that we would take back to our organization is about patient-centered care. So we did a lot of discussion around, as governors, how would we measure it? How do we engage the consumer in patient-centered care, such as focus groups, the governors going around and talking to patients. But then as the discussion went on, we started looking at what is patient-centered care? So helping to create a vision and a definition for our organization about patient-centered care. So that was our conversation.
Very good. So we've had the first, got still for question one?
We thought that we would bring back to our group a determination of the relevant benchmarks and metrics, which would be relevant to our community service type delivery. Then we would also look at best practices within our partner organizations and determine from there where we would focus our priorities. But as our discussion evolved, we actually got talking about, much like the former speaker said, not so much what is a definition. We wondered about what's the definition of quality that we're looking for. And that would be a very important discussion as well.
Okay, any more for question one, or shall we move on to question two? Anybody like to share their results of question two? Great, right here, thank you.
Hi, how are you? I think that we certainly were very influenced by the first speaker this morning, and even though we're a blend of hospitals and CCAC members at our table, I think that we all realize that even though CCAC are doing client focus groups, which sounded really excellent to us, that the approach from the NHS is very much on a one-on-one basis. It wasn't bringing people into the CCAC offices to have a focus group that we would organize, but rather that we would go out and talk to people individually about their experience, and suggestion that we would potentially even have CCAC board members listen in on the call-in line for CCAC to hear what folks are calling in about on their mind, and understanding that at the emotional level. I think we were all really struck with that part of the presentation. So I think we're going to look into that more deeply and understand a little bit how the NHS is doing that observation work. One of the things we've done with our board this year in terms of bringing more of the quality agenda onto the board table is have quality tracers following the Accreditation Canada tracer concept, where the surveyors go through the hospital and follow the patient journey. We've taken some of our quality improvement initiatives for the 11-12 plan and taken the board right to where that's happening. So surgical safety checklist, we took our board members into the operating room and then we ran through with them how the surgical safety checklist works. Most recently, we're doing the releasing time to care on 2 of our units, and we have the board members follow the nurses and understand how that's working. So I think we'll continue that because our board members like it, the staff really like it. It gives them an opportunity to see the board's interest in quality, and certainly we were reinforced to keep doing that with this year's quick targets. So.
Great, I've heard a lot of discussion around the first speaker this morning about putting the patient the center of their care, and it's really inspiring, and I think we're going to be seeing some good movement toward that. Question, anybody else have something to share for question two? Great.
We also were inspired by the first speaker for this particular question. So some of the points we had written down was much like your group, breaking down the experiences of the clients into focus chunks, as it was shown in the chart this morning, the emotional different points in the experience that the clients could describe. We talked about putting quality, this table is community agencies, small agencies, so putting quality as a regular standing item on the board agenda. The quality plan that is developed has the client in the center. The plan uses an integrated plan from the patient's perspective or the client's perspective. The language used to develop the quality plan is from the client's perspective. So it would be looked at the language would be using their experience to measure, using the client's story or their lived experience as data, qualitative data, as a measurable. These agencies have been having the clients present to the board some of their experiences and some of their projects and things like that. This is mainly a mental health table here. Celebrating client success by, at the AGM, we've done that, where we've had clients presented with awards for their experience. Qualifying client discharge experiences using the emotions and stories to describe the key points in the process. So being discharged, say, from the hospital on a Friday and following that client through maybe for 2 weeks at key points to see what their experience was like.
Sounds like some of the organizations are further down the road on this journey, so that's wonderful. Anybody else like to share? We're moving on to question 3. Maybe I'll come to this table. Oh, he's gone. He had a good story. Maybe, can Linda tell it? Okay.
So we stumbled upon a very interesting story here around collaboration. Peter took off on us, but Peter's the Executive Director of Patient Services in London. And we're with the CCAC, the Southwest CCAC. So we talked about a pilot project that they collaborated on and the mission. And as you would know, they have obviously a very transient population and a population with a lot of needs, healthcare needs, mental health needs. And so the CCAC nurse was discovering that while she set up appointments for some of these clients, they weren't coming to see her. So between the CCAC nurse and St. Elizabeth Healthcare, they've established a practice, a pilot project where they're going into the mission on, I think it was a weekly basis, and meeting with the clients there, trying to assess their health needs, meet their health needs there. This is not a population that is received all that well in the emergency departments, and when they get out in the street, they're often looked at in a way that doesn't meet their health care needs. So it was just an interesting opportunity to find that partnership sitting at this table. We thought it was an interesting story for us.
Good success. Is there anybody else that would like to share before we finish the segment?
We had an opportunity to share some information about a coordination strategy at the board-to-board meeting in Woodstock, I think it was last week. So we answered question 3, even though we thought we were in row 2. So the quality priorities that we share with several other partners, CMHA Oxford, the Woodstock and area CHC, the Ingersoll Nurse Practitioner-led Clinic, and the Addiction Services of Thames Valley. We share in some quality priorities, and this is not a full list. I think it's access to care, reduced wait times, client-centered care, collaboration and partnership. And what we have done through is to create a rotating walk-in intake for addiction and mental health clients, cross-training, shared service delivery, co-facilitation of groups. And in terms of how we'll be able to do this would be through shared calendars, technology, and cross-training. And so in terms of working with those partners and others, I think that the next thing we would do is try to move to do the same kind of thing in Elgin County.
Excellent work. Is there anybody else? Last call. It was a very good discussion, and as I said, the staff will be putting these summaries together for us, and it will be interesting to see, and we can use this as a springboard now of of information and moving forward with our quality initiatives. So at that, I'll hand it back over to Jeff.